second part of today's lecture is about the treatment of hypertension. So I told you yesterday that secondary hypertension, although uncommon, is very important, because if we identify a cause of secondary hypertension, we may treat that cause and we may be more effective in lowering blood pressure and sometimes even cure it. So the definition is secondary hypertension means high blood pressure values due to an identifiable cause which may be treatable. As I told you yesterday already, the prevalence of secondary hypertension is less than 10% of all people who have hypertension. So, of course, much lower than essential hypertension. However, the importance lies in the fact that you can be more effective in treating it. So first of all, you may have some clinical hints that may raise the suspicion of secondary hypertension when you assess the patient. Again, just to summarize, the younger the patient, the more you think maybe this could be secondary hypertension. Obesity, you may think of several causes, and we will discuss about that. Then there are some blood pressure values which may suggest a specific pattern of hypertension. We will also discuss about that. Signs and symptoms of extensive atherosclerosis, and so on. Again, I will point to this document, which I have already sent you. Miruna has it, and she sent it to you minutes ago. So I will invite you to go through this, and I will not read all these things. These are all tables that can be found in this document. So you can see here, you can see here that, for example, depending on the age group, the percent of hypertensive cases with an underlying cause may be very different. And you see, this is why we say that young patient, and in fact, in very young children, it is almost always a secondary cause, obviously. Again, teenagers, the same, a bit higher, but then you have uniformly the same percentage. And also, depending on the age, you may have slightly different causes of hypertension. However, you see renal disease, coarctation, this may often be the cause in children, in patients below 18, and then you may have other causes in elderly patients like atherosclerotic renovascular disease in patients who are old and who develop hypertension. So first of all, how do we screen for it? To start screening for a secondary cause of hypertension requires prior exclusion of particular clinical situation. So first of all, is it really hypertension? We have an entity that we call pseudo-hypertension. That is, we have, some situation when there may be a difference between the measured pressure non-invasively in the usual way and the measured pressure that is invasively measured inside the vessel. This is, for example, the case in elderly patients who have increased stiffness and in whom the measured pressure in the arm may be quite different than the pressure that you measure invasively inside the vessel. And in such cases, you may see that there is a discrepancy between values that you think are very high. On the other hand, you don't find any hypertension organ damage because it is not really hypertension, it is pseudo-hypertension. Then you have resistance to treatment or drug-induced hypertension. And this, again, you may see whether this is true resistance or is pseudo-resistance, and there may be other explanations for the measured values. And then I will show you a few of the main categories of secondary hypertension, and for each of them I have a few slides to discuss it. Let's start with renal causes. First, renal parenchymal hypertension. This is the main cause of secondary hypertension in children, the second cause of secondary hypertension in adults. It may be due to acute or chronic renal impairment that may be unilateral or bilateral, in glomerular filtration. There is a number of diseases of the kidney that can lead to renal parenchymal hypertension, from glomerulonephritis, polykidney disease, diabetic nephropathy, obstructive uropathy, tumors, trauma, and so on. Among those, diabetic nephropathy needs to be remembered because it's a common cause of chronic kidney disease in this regard. And also polycystic kidney disease is another one that you need to really take into account. How does it behave? One may have elevated creatinine associated with proteinuria or presence of erythrocyte or leukocytes in the urine sample. Those, when present, may suggest renal parenchymal involvement. One may have palpable masses in the abdomen that may suggest polycystic kidney disease. And if you have something like that at the physical exam, of course, you will require confirmation by means of imaging, most often abdominal ultrasound. And if you do renal ultrasound, this may provide important data about kidney size and shape and a few other features, cortical thickness, urinary tract obstruction, or other sort of masses in the kidney. Now, if you repeat urinary tests, serum creatinine levels, and everything is normal, you basically can rule out significant renal parenchymal disease. So you need a clear etiological diagnosis of the kidney disease before classifying a hypertension as being secondary to a renal problem. That's pretty obvious. You cannot label someone as having hypertension secondary to renal disease without having a clear renal disease diagnosis. So if you find it, obviously the treatment will primarily be aimed at the kidney disease, because I told you it is always better to treat the cause, and then hopefully secondary hypertension will also improve. Usually in this sort of hypertension, we are asked to use combination of antihypertensive drugs, because otherwise it will be difficult to control blood pressure values unless you use more than one drug. If the patient have proteinuria, then it is recommended that we use renin-angiotensin-aldosterone receptor antagonists, because we know these have a protective effect upon the kidney and may delay the kidney disease progression. So these were renal parenchymal disease. Now the second big category of renal secondary hypertension is due to renal vascular problems. So renal vascular hypertension is the second cause of secondary hypertension. And what it means is that you have renal artery stenosis that may be unilateral or bilateral, and this leads to increases in blood pressure. The main mechanisms involved in hypertension in these cases are related either to renin-mediated vasoconstriction, if there is a unilateral renal artery stenosis, and or to the excessive increase in extracellular volume if the patient has bilateral renal artery stenosis, or unilateral renal artery stenosis but a single kidney. That means also no normally irrigated kidney, because it's a single kidney with a stenosis, or both kidneys have a stenosis. So there are clinical syndromes associated with renal vascular disease. First of all, what is the primary problem? The primary problem is that you have a degree of renal ischemia, because the artery that is supposed to bring blood to the kidneys are stenotic. Then the blood flow bringing the blood flow to the kidneys is reduced. This leads to renal ischemia, and this may have combined consequences. One of them will be that the function of the kidney decreases, so you have decreased glomerular filtration rate, and this may lead to ischemic nephropathy. And on the other hand, we know that when you have a reduced blood flow to the kidney, this activates the renin-angiotensin-aldosterone system and will give rise to renal vascular hypertension. And this will be in different degrees and different severities, depending on whether the stenosis is unilateral or bilateral and how severe the stenosis is. So if you do an invasive aortography, that means you inject contrast, you inject contrast in the abdominal aorta, you see, for example, in this case, these are the renal arteries. So this is the right renal artery, and you see this is a critical stenosis here. So it is almost interrupted. So this is a very significant narrowing to the artery that brings blood to the right kidney. And this is the left artery, which also has a proximal stenosis here. Maybe not so severe as the right, but still looks significant. So in this case, this patient has bilateral renal artery stenosis. Now, what about the cause? Atherosclerosis is the most common cause of renal vascular hypertension in adults. This is often seen in the elderly, and it is usually located in the proximal third of the renal artery. The other big cause is fibromuscular dysplasia of the renal arteries. It is less often seen, maybe around 1/4 of the cases of renal vascular hypertension. And this is most common in young women. And in these cases, the stenosis is located more frequently in the distal thirds of the renal artery. So you look at the patient, the age of the patient, you look at the localization of the stenosis, and you may have a hint towards the cause of stenosis in your patient. So this is again a nice diagram where you see here some of the features in such cases. So you have some suspicion, you see impaired renal function, you may have abdominal bruits, murmurs that are related to the renal artery stenosis. Sometimes you also find other features of atherosclerotic disease. You see the patient has severe hypertension. We discussed yesterday about reverse nocturnal dipping. So these patients may be non-dipper, they may actually have increased blood pressure values at night. And another feature is flash pulmonary edema. That means these patients may enter suddenly into pulmonary edema because sometimes they may have abrupt raises in blood pressure values that will not be tolerated by the pulmonary capillary arteries and may lead to overt pulmonary edema. So in fact, you have some suspicions based on a combination of these factors, and then you decide to screen for renal artery stenosis. Usually you do ultrasound, a duplex sonography. Of course, you can also do other sorts of imaging like computed tomography or MRI, and you can directly find a stenosis. And if you find a stenosis, you will wish to confirm it with renal angiography and see whether it is significant, or it's clearly there is no stenosis, or if the result is ambiguous, you may also think you need renal angiography to sort it out. So Doppler ultrasound is the first line. You may see a decrease in the renal artery diameter when performing not echocardiography, in this case is not the heart, so we call it vascular ultrasound. And you can also find some indirect features by measuring some indices reflecting abnormalities in the flows inside the intrarenal vessels. And of course, MRI has a very good accuracy. It allows a very good imaging of the renal arteries. So you can rely on that, sometimes after ultrasound, sometimes even as the first test, but this is less usual. Or you can do computed tomography. However, when you do computed tomography, you have to remember that you need to use a contrast agent, and that may be a problem in patients who have a reduced renal function. And also you may need to remember that computed tomography involves irradiation, so it carries a small dose of radiation. So usually if you have a less toxic, a less so to say problematic alternative, you will use that one first. And finally, invasive angiography, as I've already told you, should be performed to confirm a diagnosis that is put on non-invasive imaging. However, invasive angiography is still considered the gold standard for diagnosing renal artery stenosis, and it may also be the means of treating it if you decide to have a dilatation of the stenosis at that level. So now, discussing about treatment, if we decide to revascularize a stenotic renal artery, angioplasty is the most often used method, much less often surgical revascularization. Angioplasty alone is the treatment of choice for fibromuscular dysplasia. The success rate of balloon angioplasty is lower in atherosclerotic disease because this has a higher incidence of restenosis. Most cases of angioplasty will also require stent implantation when atherosclerosis is the cause of renal artery stenosis. Drug treatment is important, and sometimes it may be the only treatment in cases when renal function is normal or preserved, if you can adequately control blood pressure values by means of drugs, if renal stenosis is not very severe, and if this has a long-standing history of hypertension. Okay, then we have also a number of factors that predict effective revascularization of these sort of stenosis: resistant hypertension, recent onset or progression to severe hypertension, recent deterioration in renal function, acute decrease in renal function during treatment with ACE inhibitors or sartans, and flash pulmonary edema, as I've already told you. So these are usually things where revascularization may be effective. When you rely on drugs, drug treatment may include thiazides, calcium channel blockers, renin-angiotensin system antagonists, unless the patient has bilateral renal artery stenosis. However, we need to be careful, and any acute renal function deterioration with an increase in creatinine may be due to a marked decrease in perfusion pressure distal to the stenosis when we use a renin-angiotensin system antagonist. So this is why in patients with bilateral renal artery stenosis, the use of renin-angiotensin system antagonist is contraindicated. So these were the main categories of renal problems that lead to secondary hypertension. Another important one, and not very rare, in fact it becomes quite common, sleep apnea. So this is one of the most common causes of secondary hypertension in adults. In fact, more than 30% of patients with resistant hypertension may in fact have obstructive sleep apnea, and mechanisms involved relate to repetitive episodes of obstructive sleep apnea caused by upper airway collapse during sleep. These lead to hypoxemia. This leads to increase in sympathetic tone, will activate in turn the renin-angiotensin-aldosterone system, may also give rise to endothelial dysfunction. So again, the clinical picture that may point to the possible existence of obstructive sleep apnea syndrome, usually you have a patient who is obese, who has a narrow upper airway with a large neck, sometimes macroglossia, again, non-dipper. These patients tend to have higher blood pressures at night. You may find left ventricular hypertrophy because of long-standing hypertension. You may find cor pulmonale as an expression of the pulmonary problem in these patients. You may even find pulmonary hypertension. And so if you find this sort of combination, you think of obstructive sleep apnea as a cause of secondary hypertension, and you go for screening. And for screening, usually we do this in consultation with the pulmonologist. And the test is polysomnography, which may quantify the episodes of apnea or hypopnea. And based on the number of such episodes, you may grade this as a mild, moderate, or severe form of disease. It is important because it has a specific treatment, and the treatment may be continuous positive airway pressure ventilation. You may ask these patients to sleep with this sort of a mask on their face, which may be a problem because some patients will not agree or will not tolerate it. But if they do, it may reduce the problem. It may lower blood pressure values, and this may help all along. Apart from that, again, these are obese patients. We need to treat obesity by weight loss, and we also recommend them to avoid alcohol, to quit smoking, and to be more active physically. So keep in mind this syndrome because it's quite common. And then a number of endocrinological causes that are quite rare, but are important to be identified because, again, there may be a specific treatment. First of all, pheochromocytoma. This is very rare, 0.2 to 0.4% of all cases of hypertension. In 90% of cases, these are tumors of the adrenal medulla and predominantly secrete epinephrine, okay, adrenaline, the paravertebral ganglion chain, and predominantly secrete norepinephrine. So hypertension occurs in approximately 70% of these patients who have pheochromocytoma, and when it occurs, it may present either as a sustained hypertension or as paroxysmal hypertension. When do we suspect this? The classical description is that of the hyperadrenergic crisis related to the release of epinephrine or norepinephrine in circulation, and this may lead to palpitations, sweating, headache, tremor, pallor. There is a pattern of usually resistant hypertension. Sometimes there is a family history of pheochromocytoma. Sometimes you may find incidentally an adrenal mass. For example, you do an abdominal imaging study for some other reason, and then you see a mass, or you have new onset of hypertension and diabetes, or there is an early onset of hypertension in a very young patient below 20. So again, classically, a hypertensive crisis is described a classic triad, 3 signs: severe headache, palpitations, and sweating, to which one may also see pallor or paroxysmal hypertension. And this may sometimes be triggered by an external factor that may be trauma, anesthesia, surgery, and it may unmask this. How do you diagnose it? So first of all, you have the clinical suspicion on the grounds that I've described, and then you do some tests. Plasma metanephrines can be measured. If you find normal levels, this makes the diagnosis of pheochromocytoma unlikely. Alternatively, you may also find changes in the urine, or you may find plasma catecholamines. And then, of course, based on this suspicion, you do an imaging test to look at the adrenal glands. As I already told you, either ultrasound or MR-CT may show you how this looks and may diagnose the existence of a mass at that level. How do we treat it? We have medical treatment, and this is usually the one that you start with. Sometimes you need intravenous treatment because the increases in blood pressure values may be quite severe, so you need a very rapid way of decreasing blood pressure values. You may use sodium nitroprusside, labetalol, or nicardipine. You should not use beta blockers as a monotherapy unless you have adequate alpha blockade. And usually the curative treatment is resecting, taking out the tumor. Sometimes you do this with laparoscopy because, again, this is a causative treatment and may lead to the cure of hypertension in such cases. Last but not least, an entity which is not very common, but it's very important from a clinical standpoint, is aortic coarctation. Does anyone know what this means? What does it mean, aortic coarctation?
Is a
Narrowing
genetic birth
aorta?
defect?
Sorry? Go.
Is a genetic birth defect?
Yeah, this is a congenital problem. It's true. It's congenital. But what does it mean?
Narrowing aorta?
Sure. Yeah, so there is a narrowing at the aortic level, most commonly in the proximal part of the descending thoracic aorta. But sometimes you may have also abdominal coarctation. Basically, there is a narrowing at the aortic level, which, if severe enough, will create a higher pressure proximal to the narrowing and a lower pressure distal to the narrowing. Okay? And because this is after the emergence of the subclavian artery, it means that the blood that goes to the upper arms, the upper extremity, are proximal to the narrowing. So you will have increased pressure there. So you will find hypertension of the upper extremity. However, if you measure the pulses and the blood pressure in the lower extremity at the legs, you will find reduced or even absent pulses and reduced or even non-measurable blood pressure. So this is a very common feature, and this is why I told you yesterday, when you first assess a patient, you need to take the blood pressure in both arms, because in this way you can diagnose stenosis at the subclavian level, but you also need at least to palpate the pulses both at the arms and at the legs. And sometimes you will see there is a very big difference. You have a good pulse at the arms, but you barely feel the pulse at the legs. And then you may wish to measure blood pressure in the legs. You will find it significantly reduced. Sometimes in severe cases, they may be inferior body hypertrophy. So muscles are not so well developed, pilosity is reduced, but this is quite extreme. In fact, you have a young patient, you have high blood pressure, so you have to have an increased index of suspicion, because it is so easy to diagnose. You just have to examine the patient at the bedside. Then, of course, you may find hypertrophy, you do an echo, and you confirm the diagnosis. So here is a diagram, and you see this is the ascending aorta, this is the arch. You have the arteries that bring blood to the brain. You have the left subclavian artery. And then here, at the isthmus level, in the initial part of the descending aorta, you have a narrowing. This is why you see that the blood pressure in these vessels will be increased, while the blood pressure distal to the narrowing, most easily measurable in the legs, will be decreased. However, one more thing for you to remember, you need to remember from the anatomy that we have an artery called the internal thoracic artery coming from the subclavian artery. And this artery is very important in patients who have coronary artery disease. Why is it so? Do we use it at anything? Do we have an idea?
Yes, for bypass.
Sure. So this is a very common graft that is used, and is actually the one that you should aim for. You know that when you put a graft on the coronary arteries, ideally it should be an artery instead of a vein, because arterial grafts have a longer history. So the patency of these grafts is much better in arteries than in veins. So this is called also the internal mammary artery or internal thoracic artery. We use it as a graft. But this is a parenthesis, does not relate to our course today. What I wanted to tell you today is that in patients who have severe coarctation, as I told you, always the body tries to adapt to a problem, okay? And tries to find ways to adapt. So for example, if this patient is a patient who has long-standing coarctation that is very severe, distal to the obstacle is very low. So how does the body try to adapt? By developing collaterals, okay? So what does it happen? These intercostal arteries, because the pressure will be high in the all the vessels proximal to the narrowing, including in the internal thoracic artery, this will increase the caliber of the intercostal arteries and will try to bring blood to the descending aorta distal to the narrowing. But this will lead to a sign, and this is called rib erosion. These are the ribs in a magnified view of a chest X-ray. You see them? And sometimes, in some cases, you may see some erosions of the contour, the inferior contour of the ribs. So instead of being a very smooth contour, as you see here, there are some irregularities, rib erosions. Why is that? Because the intercostal arteries run along the inferior aspects of the ribs. And so if that artery is increased in diameter and is also pulsating because it is an artery, with time, chronically, it may lead to some erosion of the inferior aspect of the rib. This may be a sign that you may find on a chest X-ray, okay? So you have to think about it and learn it logically. And then, of course, you have echocardiography that may show you the problem. This is a suprasternal view. It means you put the transducer above the sternum here. And so what you see here, this is the aortic arch, which is quite dilated because it sees a high pressure and it gets dilated. And then you see a narrowing. You see the difference in caliber is big here and very narrow here. The flow is turbulent at the level of the narrowing, and the velocity of flow is significantly increased because with Doppler we can measure differences we can measure velocities and translate these velocities in gradients, in difference of pressure. Whenever you have a narrowing, you will have a difference in pressures between before and after the narrowing. This is also the case with valves. If you have a stenotic valve, you will have a difference in pressure, higher proximal to the valve or to the narrowing, lower distal to it. And by measuring the velocity of flow across a narrowing, you will be able to quantify the severity of the narrowing. And then we have treatment. So this is how it looks at our orthography initially. You can see here It's quite narrow, but then you inflate a balloon, you dilate a vessel, and you see after the diameter is pretty good and pretty similar to the arch. There is no residual gradient between the two sides, and usually this restores the pulse at the level of the lower extremities, and sometimes blood pressure get back to normal, or sometimes they don't normalize, but the patient will require less medication to control the blood pressure values. So this was the part related to secondary hypertension. Now I will go to the second part related to treatment. And again, I'm not trying to be exhaustive. You can find all of that in the guidelines, but I'm just trying to highlight a few principles and a few essential information for you to know. Again, what we've discussed today, global cardiovascular risk assessment, always important, because you have a patient, you don't have parts of a body. So you have to look at the patient as a whole. So you do this global assessment in order to decide when to start antihypertensive treatment, how intensive this treatment should be, and which targets you use. What are the goals of treatment? We would like to prevent target organ damage. We would like to prevent occurrence of cardiovascular events. Of course, either non-fatal and fatal. If these had already happened, target organ damage, we would like to reduce it, to have regression, or to delay it, because this will translate in a benefit in terms of morbidity and mortality. How do we decide when to initiate treatment? We look at blood pressure values and again, global cardiovascular risk. So a few principles. Lowering blood pressure per se, independently of which therapeutic strategy we use, represents the main benefit in reduction of morbidity and mortality. Because you will hear, you need to use this drug and not the other drug, you need to do this or that. In fact, what you need to do is you need to reduce blood pressure. Of course, you will need to decide of a drug or another based on several issues that we're going to discuss, but the most important thing is reducing blood pressure per se. Lifestyle interventions. So we don't immediately jump to drugs unless the patient has really high measures. But lifestyle interventions are very important, either alone or combined with drug treatment. And these are a few of them. You also see, we discussed before about classes of recommendation. 1A is the highest level possible. So salt restriction may sound trivial, but is extremely important. Restrict alcohol consumption. Less than 2 drinks per day for men, less than 1 drink per day for women. Increased consumption of vegetable, fresh fruits, fish, nuts, Mediterranean diet, low consumption of red meat, okay, and low-fat dairy products. All of that is 1A. And also related to this, avoid binge drinking, holiday drinking. You go on a party and you get totally drunk. Of course, this is not good for many reasons, including for hypertension. Control the body weight, very important. I told you it's important to treat obesity very actively. So you try to avoid obesity, you try to reduce abdominal obesity by reducing waist circumference. Best way is to have healthy body mass index, that is around 20 to 25, and normal waist circumference values. Do regular exercise, at least half an hour, at least 5 days a week if possible, of moderate intensity. Again, 1A, highest level of recommendation for simple measures. We tend to forget this, but this is crucially important. Smoking cessation, supportive care to help with smoking cessation, also extremely important. So these were like lifestyle intervention. Then how do we go about drugs? We can have a core strategy for drug treatment in patients who have uncomplicated hypertension. And this has some principles. Usually you start with an initial therapy, which may be dual combination already. You should consider monotherapy if patients are really low risk or very old. You start with just one drug. Otherwise, you may try to start with the combination, because the combination may have the advantage of using lower doses from each of the drugs and selecting them to have a complementary effect, to potentiate the good effect, and by using a lower dose to avoid the side effects of each of them. So this is the principle. Then, if this doesn't work and doesn't control well enough blood pressure values, you can add another one. So you have triple combination. And then you can add another one, you can have 4 drugs. So we take it in a step-by-step approach. And usually we consider that beta blockers are not the first line therapy unless there is a specific indication for their use, because the patient also has something else that mandates the use of beta blockers. Heart failure, where you heard that beta blockers are very important, or coronary disease, angina post-MI, atrial fibrillation, where you use beta blockers to control the heart rate, and so on and so forth. Otherwise, in the absence of these indications, we usually start either with ACE inhibitors or calcium channel blockers or diuretics. There is another thing, the single pill. So whenever possible, it has also been shown that if you put in a single pill several substances that you wish to use, that is may be important, because always the patients prefer to take less pills, so the compliance with treatment will be better. We know that. So this is also something you may wish to consider. And then we have a number of recommendations that I will again not go through in detail. I will not read all of that. But as you see here, these are recommendations based on several factors related, for example, to a specific situation when there is a preference of one or the other. I told you about beta blockers, combinations. I told you about the principle of starting with either of these 3 classes. And so if blood pressure is not controlled with the 3-drug combination, treatment should be increased by adding spironolactone. That is another principle. Spironolactone is a different type of diuretic, but it has been shown that in resistant hypertension, this may help decrease blood pressure values. And of course, in the end, if you are a general practitioner, you have severe resistant hypertension, you will also refer the patient to the specialized care. We also have to avoid the combination of 2 renin-angiotensin system blockers. We don't use at the same time ACE inhibitors and sartans, because they work through the same mechanism. What about the range of pressures that we use? I showed you yesterday that we have different values for different settings. So this is for office systolic blood pressure ranges. And then you see that based on the age and based on the coexistence of other problems, you may have different targets. And this is important to look at. Sometimes you wish to be a little bit more aggressive. For example, if you have a middle-aged or young adult who has diabetes, your target may be lower because diabetes means already high risk of that patient. So you may wish to reduce the risk. However, even in those cases, you don't want to reduce it very much because reducing it very much may have side effects, both in terms of symptoms and in terms of organ perfusion. So there is a balance. You wish to reduce it to a normal range, sometimes even lower. However, as you see here, especially in young and active people, you don't want to reduce it extremely low. And then also in elderly above 80, you usually target the high normal. You don't need to bring them very low. They may also be more symptomatic if you reduce it too much. So something around 130 to 139, if it is well tolerated in your individual patient, that is the range you look for. Okay? And diastolic blood pressure, you would like to have it in the normal range, but again, not extremely low, 70 to 80. And finally, I have a few slides that I will ask you to look into detail in the documents that I've sent you in the slides. So this is concomitant conditions the patient has that may favor the use of a specific antihypertensive drugs. Okay? So this you already know from other diseases. Again, beta blockers, we use it in patients who have heart failure, coronary disease, tachyarrhythmias. ACE inhibitors we use when it's heart failure, LV dysfunction, diabetic nephropathy, proteinuria, and so on and so forth. Diuretics we may use in heart failure or renal disease. So we have a number of features that we look at when we decide which drug to start, because I told you the good news is that we have the liberty to start with either of some classes. So then we will tend to choose which one to begin with, depending on the other conditions that the patient may have. The other part, when do we not use one drug? Contraindications. Again, we have absolute contraindications, compelling contraindications, or relative ones, possible ones. That means you should avoid it. However, you may use it if you think the benefit is really good. So this is also an important table because you may not wish to give a patient some drug that is totally contraindicated because you may harm the patient. For example, if the patient has grade 2 or 3 AV block, of course you will not use beta blockers because you may even stop the patient's heart. True asthma, truly diagnosed asthma, if you use beta blockers, you may produce a bronchospasm that may be even fatal to the patient, and so on and so forth. Bilateral renal artery stenosis, we've just discussed. You don't use ACE inhibitors, you don't use sartans. Hyperkalemia, we know that ACE inhibitors and sartans lead to hyperkalemia. So if the patient already has hyperkalemia, we will not use those. So keep this into account. If the patient has GOOT with very high acid uric values, you don't use thiazide because this may aggravate very much this condition. So you need to know the contraindications, you need to know the situation where a drug is preferred, and based on that, you will choose the drug. And also I find this diagram pretty useful because some drugs go well together in combination. Some drugs are not the best choice to combine them. Again, not totally contraindicated, but you may wish to consider that. The continuous lines mean that those classes may be combined well together. The dashed lines mean that those combinations you would rather prefer to avoid, either because they have a similar side effect or because they act through the same mechanism. So when you use a combination of drugs, you usually try to select drugs that act through different mechanisms so that you can be more effective in your overall treatment. Finally, I just have 3 more slides about resistant hypertension. I told you that means that blood pressure remains above target blood pressure values as we defined it previously, despite appropriate lifestyle measures and antihypertensive treatment using at least 3 drugs, including a diuretic. So this is the definition. We've already discussed pseudo-resistant hypertension. Sometimes depends on the measurements. Sometimes it's a white coat phenomenon. It is increased when the patient comes at the office, but it's normal when he goes home. So that's why I told you yesterday we need sometimes to think of ambulatory blood pressure monitoring. Sometimes the patient tells you he did all it takes, but in fact he still, drinks and eats salty and so on and so forth. It is usually important to also discuss with the family and see whether this is true, because the definition says despite appropriate lifestyle measures, okay? You need to assure that. Sometimes he doesn't take the drugs. So you see, I give you 3 drugs, maybe the patient doesn't take them. Maybe he forgets, maybe some other reasons. So you need to keep this into account the best way you can. And then if it's truly resistant, you think of some causes and you think of some situations that may keep blood pressure high and lead to resistant hypertension. I told you, sleep apnea, chronic kidney disease, undiagnosed renal vascular disease, these we already discussed. These are more common. And sometimes it's some drugs. There is an old lady who has some sort of arthritis, he has joint pains, so he takes a lot of anti-inflammatory drugs. These tend to retain salt and water and tend to keep blood pressure higher. So whenever possible, you should also ask the patient what other drugs is he or she taking. And sometimes you may find that some of the drugs they take on a regular basis interfere with the hypertension treatment that you are recommended. Of course, sometimes they need to take those drugs, so you cannot stop them, but at least knowing you need what is the best approach. So how do we deal with this? Again, after making sure it's truly resistant, we optimize the treatment. We should have a diuretic combined with the others, and we try to make sure that there is a proper diagnosis of resistant hypertension. You try to exclude causes of pseudo-resistant hypertension, especially poor adherence, which is sometimes not easy to diagnose because the patient is telling you he's taking them. And how do we treat that? Again, we start from scratch. Lifestyle is important, sodium restriction, adherence to treatment. If all of that is taken, then we may add low-dose spironolactone, I have already tell you, or we may add some other diuretics if the patient does not tolerate spironolactone, or we may add a specific beta blocker or alpha blocker. Okay. There is another table about emergencies requiring immediately lowering of blood pressure values. So this is really important. Most often you use IV drugs, infusing them, and you have specific targets to try and reduce mean arterial pressure or systolic arterial pressure to a specific range depending on the clinical situation. And finally, what is very important, and with this I'm closing the lecture, again, we are talking about a chronic treatment that the patient will need to take all his life. That means you really need to talk to the patient to make sure he understands the importance of treatment. I showed you yesterday in my initial slides that there is a very poor control of hypertension, and this relates often with lack of compliance of the patients. So if the patient does not believe you how important it is, he will not take the drugs. If the drugs you recommend will give him important side effects, for example, erectile dysfunction, this is a sensitive issue. He may be shy to report it. He will say, well, I do this, I would. So it's important to discuss with the patient and try to find together with him the best scheme along the principle that I've presented you. Make sure he tolerates it, make sure he buys into the concept, because again, this is a very long run that he needs to have. And if the patient does not take the treatment and the blood pressure is high, you didn't do a good job as a doctor, and the patient will be at risk of very bad events. Sometimes you need to write down some principles, you need to explain, you need to involve the family, sometimes you need the help of a psychologist. So anyway, it is a teamwork involving the patient, the family, some other healthcare providers, but it is crucially important that you succeed, because otherwise, I showed you, there is a lot of morbidity and mortality. So at the patient level, sometimes group sessions, they may talk to other friends, motivational strategies, reminders. Now there are all these smartphones that may be used to remind them not to miss pills. This is the time you should take your pill. Sometimes you forget, you're busy. Family support, drugs at the work site, all of them. And from our part, again, whenever you can shrink the number of pills that the patient has to take in one way or another, excluding useless medication or less important medication, combining several drugs in a single pill, all of the measures that improve compliance are very welcome, because they may help with the best result of the patient. So that's basically what I had to tell you. And again, this is a comprehensive topic, very important. We didn't, cover it completely in these two lectures. I tried to highlight the most important things here, but I invite you to go through the slides again, which you have received, and also go in detail through the tables, both those in my slides, but also the others that you can find in the European Society Cardiology Guidelines on Hypertension. Are there any questions to this?
No, it was clear.
It was clear. Thank you.
Okay.
Thank you.
Great. So That was it. If there are any other things, practical or questions, we will keep in touch through Miruna, and soon we will get back to you with details about the exam. You already know about it because we've discussed in our first lecture. Most likely it will be on the 10th of February. But again, we will go back and we will explain to you. For the moment, again, I remind you what I told you yesterday. Attend the classes. All the classes are important. And not just to enter the exam, not just for administrative reasons, but I believe they are important for your formation as doctors. Okay, if nothing else, then I wish you a good weekend. Stay safe, and we keep in touch.
Thank you.
Thank you.
Thank you.
Thank you.
Thank
Have a
you.
nice weekend.
Thank you. Nice weekend.
Thank you.